So good morning, everyone. So hope everybody enjoy this day in Japan and nice travel. So this session, so first talk is Dr. Jianyi Zhang from UAB, Alabama University at Birmingham. So title is Mod RNA Therapeutics versus Human iPS cell-derived cell and cell produced for myocardial repair in large mammals. Please, Doctor.
So this is a big topic for 18 minutes. Fortunately, I just followed Dr. Zhang's talk review past 40 years of gene therapy and RNA therapeutics. So I'm trained by Jay Cohen and Bob Aki. So as a physiologist, everything sees by naked eye. I don't need to go to detail, but all the mechanisms and mechanistic findings are from Dr. Zhang's previous talk. So this is a perfect match for the next 18 minutes. So I try to finish the talk in 18 minutes and then 2 minutes interaction with my colleagues. So I will report to you as following. This slide illustrates one of the most significant problems. That's why we are all here to examine if any therapeutics can remuscularize injured ventricle, as shown here. This is the heart with a post-infarction alveolar remodeling multi-slice illustrate from apex to base. Arrow points to a thin piece of scar that because of acute myocardial infarction happened 4 weeks ago. So this is a pig heart with 4 weeks after acute myocardial infarction. It has LV dilatation, mitral regurgitation, and end stage of clinical heart failure, which remains to be one of the most significant clinical problems in today's world, post-infarction LV remodeling of heart failure. So if we can remuscularize this last piece of muscle, we may save lives. And as we all know, the infarct size is linearly related with the progression of the LV remodeling heart failure and death. So remuscularize injured ventricle has been success in immunodeficient rodent, as shown here, that injection of human iPS cell-derived MHC-driven cyclin D2 myocyte into the heart of rodent with immunodeficiency. These myocytes continue to proliferate. By 4 weeks, it has significant piece of human muscle in the heart, as shown red. This is a human-specific troponin T, and white points to the human-specific nuclear antigen, demonstrating a human piece of muscle in the rodent heart 4 weeks after the transplantation. This, again, is immunodeficient mice. And by 6 months, as you see the yellow piece showing the confocal of red, that's human-specific troponin T in confocal with the green shows yellow. So these MSC-driven iPS-derived myocytes over the times continue to proliferate, generate more than 50% of LV lost myocardium. So this is immunodeficient rodent. I will take a little bit time to talk about the cell products in the remuscularization. So this slide illustrates on the left is a report that showing the exosome that is secreted by the human iPS cell-derived cardiac cells, including endothelial smooth muscle cell and myocyte, improve the recovery from the myocardial infarction in large mammal. And on the right side is a report in 2021 that, again, these are the injection of human iPS cell-derived MHC-driven myocyte. That is the cyclin D2 overexpression enhanced the efficacy of a human iPS cell-derived stem cell-derived cardiomyocyte for myocardial repair in the pig model. So this is mechanistically, we demonstrate in this report showing that it is the exosome released from the cardiac cells derived from the human iPS cell that inhibit the last two, which prevent the phosphorylation of the YAP leaving the cell and goes to internalize to the nucleus, which promote the cell proliferation as evidenced by the KS67, PH3, and Aurora B, and which is accompanied by decrease of LV scar and improved LV function in this pig study that was reported in 2 years ago in Circulation. In the next few minutes, I'm going to take your time to talk about the neonatal heart regeneration in large mammal. So this shows the Dr. Hashan CDAC lab reported in Science 2011 that we were surprised to learn that the mammal can regenerate ventricle, but only happens within the 7 days after the birth. So this shows the apex resection of heart at the P. So this is a subgroup of animals have apex resection the explant heart in day 2, day 7, and day 21. So by day 21, the apex is replaced by a piece of muscle. So that demonstrates the mammal can remuscularize injured ventricle just like a fish and snake, but only happens within 7 days after the birth. So we have since worked with UT Southwestern Dr. CDAC lab to examine if remuscularization of myocardial infarction in large mammal can occur. And two, if it can occur, whether we can extend the time window beyond the postnatal day 7. And if that can be achieved, we want to identify the regulators that regulate the cell cycle in large mammal. So this is, we have been working on this, supported by NIH, and for the past 10, 15 years. So in 2018, there's 2 reports in the same volume showing that the large mammal, specifically in pig, can remuscularize injured ventricle as well, but only occurs in postnatal day 1 or day 2. By day 3, if you do AOD ligation, it ends up a large piece of scar. So in this study, one from the Birmingham, the other one from the Singapore National Heart Institute, demonstrate that a pig comes in the lab, does the P1 AOD ligation, P2 AOD ligation, P3, P7, P14 AOD ligation, and examine the heart 4 weeks later. We found that only postnatal day, within day 2, if you do an AOD ligation, the heart can regenerate. It's just like in the fetal heart can regenerate. So then we ask if these regenerating heart, large mammal, what will happen if this regenerating heart will expose to a heart attack? So we did exactly that. This shows that the control group, we have a double injury. So postnatal day 1, animal comes in, have apex resection to have a regenerating heart, and the animal allowed to recover. By the P28, we have a second injury to open the chest and ligate the AOED, and chest closed by layers. And 4 weeks later at the P56, we bring the animal in, and before explant heart, we do the cardiac echo, MRI to examine the infarct size and function. And the study group is compared to 3 control groups that including the non-regenerative heart, meaning that the heart has not exposed to P1 injury. At the P28, we just do AOD ligation. And then similarly, 4 weeks later, we explant heart to compare. And in order to examine the single cell nuclear RNA sequence, so we have the naive heart coming in at the postnatal day 1, day 28, and day 56 to explant heart examining the single-cell RNA-seq and gene expression. And finally, we have another group that is the fetal heart at the embryonic day 80, that's minus 30 of the P at the birth. So fetal heart, N equals 6, explant heart examining the single nuclear RNA-seq. There's lots of data in the past 5 years. We've done hundreds of pigs examining the single nuclear RNA-seq bioinformatics, and this is, again, as a trained physiologist, we see by naked eye. So you can see this is a typical heart from inside out. Look at the anterior wall, that animal have double injury, P1 apex resection, and P28 LAD ligation. There's no scar, and we look very carefully, short axis view, long axis view, MR imaging, the double injury, P1 apex resection, P28 LAD ligation by P56. There's no infarct we can find. It's just like the fish snake heart. And on the right side, you can see a yellow arrow points to LAD ligation, and down there, the apex is supplied by the collateral flow, as you can see clearly. So remuscularized apex or LAD septal wall is supported by the collateral flow. So there's lots of data. As I said, we've done multiple groups of animal, and hundreds of pigs studied, neonatal pigs studied. And the summary as shown here, we have established a large mammal neonatal model with double LV injury, and established for the first time to prolong the window of remuscularized myocardial infarction to P28. We have generated single nuclear transcriptome of cardiac cells from neonatal, naive, and injured pig heart. The regenerative heart maintains a population of P1-like immature cardiac cells, which continue to proliferate and contribute to a prolonged window to P28 of remuscularized injured ventricle. The pathway analysis indicate that the activation of multiple factors such as PCAM2, Hippo-YAP signaling pathways in cardiac cells population that are responsible for the increased machinery of myocyte proliferation response. Ongoing study aim at identify the regulators and the signaling pathway that govern the cardiomyocyte cell cycle in neonatal pig. We aim at targeting these regulators in adult pigs with the modified RNA technology to remuscularize adult heart with acute myocardial infarction to prevent the LV dilatation and heart failure. And this basically is under the NIH leadership, PCTC leadership, this is the PPG for next 5 years, actually. And I will take the next 3 minutes to tell you what we have found in the past 12 months or the 3 years. So this is one study, unpublished, so just be aware that the study is unpublished, being reviewed. So the aim, we used modified RNA to targeting the PCAM2 as a targeting gene. So the modifying technology specifically, that's the cardiomyocyte specific modifying translation system, was established by Leo Zhang's group. This was published in 2020 in Circulation. So good science that everybody can reproduce that. We use the technology independently. So this is independently, we follow their report. We generate this system. It's called the SMART system. basically it's have including two modifier RNA. One is the suppressor modifier RNA that including seed sequence that in this case it recognize the MySide. It's MIR1 and MIR208. And the second modifier RNA is was the gene of interest, and before that is the K motif that regulate the translation. So when you inject these cysteine to the heart, in MySide, when there's myocardial infarction, the sequence recognize the MIR1 and MIR208. So this modify degradation. And the second modifier continue without inhibition to produce the gene of interest of the protein. So in MySide, the regulator gene. In the non-MySide, because there's no MIR1 and 208, so that's the first modifier RNA is continue to go on to produce in this case, it's L7AE protein. This protein binds to the K motif in the second modifier to prevent the translation to occur. So that's a simple cysteine to make the cardiac-specific MySide gene editing. And as shown here, this is in vivo rodent demonstration of the, in this case, with the protein of interest is GFP. So as you can see, only the MySide that effective with this smart system is showing in yellow. That is the confocal of green. That's the GFP and the cardiac-specific troponin T, as shown here. So in MySide, in the heart, when we compare to the control group, the vehicle group have a big scar, as you see by your naked eye, and the top panel from base to apex, and one was the smart system, the significant decrease of LV scar. That's quite significant. So that's what I'm become a believer of the NMR modified therapeutics has a great future and a new chapter. So I will finish here. I want to take a few minutes to answer questions. And this study will not be possible with my collaborators, that including the doctors Camp, Ger, Jamie Thompson from Madison University, Wisconsin, Tim Towns, Jack Rogers, Vladimir Fast, and Wilcott from UAB, and my colleagues in Duke, that Dr. Bosak, Dr. Saul Rockman, and Dr. Gary here in Minnesota, Dr. Zhang from Mount Sinai, and Dr. Sidak from UT Southwestern. And we appreciate NIH support for these years of basic science research. Thank you.
Question, please.
So the COVID gave our new life in medical science. Dr.
Beautiful presentation, Jay. Thank you for that. Eduardo Marban published a really interesting paper. I don't think it got a lot of attention. It was in December of last year, where he was giving mRNA, modified message RNA, and I think it was PKM2 was his target. And what he found was that initially there was, actually it wasn't PKM2, I'm sorry, I misspoke. It was TBX18, because he was trying to induce biological pacemakers. And what he found is he didn't get much of an effect with the mRNA injected directly into the heart. But what he noticed was that there was an increase in microRNA against that specific TBX18 mRNA. So it suggests that anytime we give messenger RNA, we might have the tissue that is being treated might have a reaction to that, might actually increase the microRNA library against that messenger RNA. I don't know if you saw that, but he went on to show the same thing with VEGF messenger RNA. By putting in antagomeres against those microRNAs that were generated in response to the messenger RNA, he got a better effect.
So, John, that's Dr. Marban's work, Dr. Eduardo Marban's work?
Marban, yeah.
Yeah. So I didn't, well, I can speak for Eduardo, but we believe and that the data actually supporting that the regulator of myocyte cell cycle is multiple factors. So PKM2 is one of the key regulators. We have targeting other regulators that also can turn back the clock of myocyte proliferation. And this is quite amazing system, and it's simple. It's probably Mount Sinai or Kenshin worked on that. They all patent protected, but we worked independently with this smart system to target the gene of the myocyte specific. The key here is the myocyte specific. And then we turn on the PKM2, which is regulate the beta continuous system and also the metabolism system to regulate the cell cycle. But we're also targeting the other molecules such as D2, we are in the proposal we try to targeting other regulators also. So probably it's a multiple factor regulate the cell cycle, make the cell after the birth suddenly within day 2, the stop cell cycle. But if we effectively targeting one gene successfully, it turns back the clock. If we can targeting multiple genes at the same time, it's probably more efficient. But I'm very excited to see these data by naked eye. So, but we work together. If we have something, we'll send stuff to your clinical grade production of the therapeutics will probably be more exciting in clinical trials. Thank you.
Jay, I have 2 questions.
Yes.
The first question is that in your large animals postnatal regeneration, have you really demonstrated that the regeneration is all from proliferating myocytes?
Yes, yes. So the question is if that's from the myocyte. So we have 3 lines of data. One is showing the cell cycle chromosome activity by PH3, KRC7, and Aurora B, specifically as that's the Aurora B in between the 2 cell cycle membranes. So the symmetrical and asymmetrical Aurora B. So that's at the protein level. And in culture, now we have the human iPS to derive the myocyte. So we can culture for weeks and make the myocyte in senescence, right? Yeah. Senescence, they are not divided. And
but that's in vitro.
That's
right?
in vitro. So we hit that's in vitro. So in the staining, we show that's the symmetrical Aurora B. In vitro, we have myocyte senescence and hit the microRNA. It start to turn on the product. So that's
I'm
in
only
vitro.
asking a question because I don't think the jury's out whether at that early stage you don't have progenitor cells. So it's
no, we don't have data to demonstrate there's a progenitor
So
cell.
then if you go towards an adult heart, this is a big lift in terms of being able to switch these cells to proliferation. My second question is delivery. How do you deliver those smart systems?
Yeah. However, let me finish the data. So we know there's no significant cardiac stem cell in the adult heart, but the large mammal in vivo newborn neonatal heart. This question has not been examined, so we cannot completely exclude that. Yeah. And then another possibility, how much protection it happens in neonatal heart. That's also because you can only do TTC one time. The cell can only die once. So the cell may be in this neonatal heart, they have injury, TTC cell that shows the positive or negative, but these cells may have the recovery also. That's question still be examined. But your question about the delivery, so in this, the preclinical study, we do direct myocardial injection. So ongoing study, we are share with you, we are using the lipid monolayer to engulfing the modified RNA. We try to do IV delivery, have a targeting to the injured cell. So these are ongoing study. We have a plan to do that. It will take some years to identify that.
So next question, last question. Sorry, I'm sorry, last question.
2 questions, I guess.
It's okay, we have time, so we'll take advantage. I'd like to interact.
I
So
give you a lot of
question,
time.
please. Yes.
Good morning. Sanjay Sinha from the University of Cambridge. Thank you for a really great talk. I'm very excited by the way that you extend the regenerative window in your neonatal pigs. You also showed that when you ligated the LAD, there was revascularization as well. But how extensive is that revascularization? Is it sufficient? Have you looked at ischemia or perfusion into that regenerated tissue?
So thank you for asking the question. I trained by Barbaki and Jay Cohen. So as a physiologist, I have done over thousands of dogs, over thousands of pigs. Do AOD ligation and a big piece of scar. I don't have time to show the slide. There's no question at all. So if you ligate the AOD in pigs, you end up a big piece of yellow scar, anterior septal wall. There's no question about that. I've done over thousands of dogs, over thousands of pigs now. So that's one of a control group. Control group coming in without apex injury, AOD ligation, big piece of scar, just like I showed earlier. So this is, anybody can do that. In large mammal, you have AOD ligation, big piece of scar. If animal do not die on the table, 4 weeks later, a big piece of scar.
Short answer.
Sorry, please, quick last
So
question.
great talk, Jay. Just have a quick question. If you give this CM Smart cocktail to animals without myocardial infarction, do you expect to see cardiac hypertrophy, or have you done it to see if there is any change in cardiac proliferation at baseline?
So the question is, what will happen if the smart system give to the normal heart?
Without injury, yes.
Without myocardial infarction. So that's actually, I can speculate. We done the control group with the myocardial infarction, or the control group was without targeting the PKM2. I would speculate the smart system applied to a normal heart will turn on the clock also. But that's an interesting question. We probably should examine that to have the data to tell you.
Okay.
Okay.
Thank you.
Yeah, thank you.
Thank you very much. So now we move to the next speaker.
It's my great pleasure to introduce Wolfram Zimmerman. His topic is going to be on tissue engineered heart repair from monkey to human.
Victor, thank you very much for the introduction, and of course, also thank you very much to Kaichi Fukuda for organizing this excellent meeting, and for Jay and Dennis for having been able to bring us together for the past many years for the PCTC. And finally, I'm quite surprised that you managed already after less than 1 hour into the meeting to be 1 hour before time. So that typically doesn't happen too often at this meeting. But I still will try to get through my talk within the time that I have been given. If you could share it. Okay, thank you very much. So we work on tissue engineering for a long time, and I just give you a brief overview of the technologies we have been using, which have been pretty much the same from the start of our tissue engineering work in rodent models, and of course have been refined a little bit to improve the tissue formulation to be able to use these tissue patches also clinically. The general concept for the clinical approach is to use induced pluripotent stem cells and derive cardiomyocytes and fibroblasts from those cells and bring them together in a collagen hydrogel, and then basically use a cast molding procedure. If you want to be fancy, you can call it 3D printing by hand, but it's a pipetting procedure where you basically pipette a mix of cells and collagen into a mold, and the mold you can basically choose pretty much as you want, as long as you take care of diffusion and some other design principles. And of course, those tissues can then also be scaled. They can be scaled relatively easily in X and Y, and they also can be scaled in Z, depending again on the design principle to allow sufficient perfusion. And you can see here on the bottom a couple of tissues that we have developed over the time. patches, fused individual rings or pouches, and these are for applications either on a scar ventricle, on a localized scar, or, for example, in patients in which there is dilation of the heart. The top right is the tissue formulation that we are presently using for clinical application, and I will just walk you through now the preclinical data that we have obtained in monkey primarily, and then also give you some insight on the ongoing clinical trial. If I can move this slide. So, what you see here is a monkey heart from the rhesus macaque, and on the right-hand side you can see a rhesus macaque EHM. This is in scale. This is the lowest single dose unit that we are preparing also for clinical applications. You can see they are quite large. When doing these, why did we do this monkey study? We did the monkey study because our regulators told us that they don't want to see a xenograft study for approval of our trial. They wanted to see an allograft study or an autograft study, depending a bit on our strategy. And they wanted a large animal model. They wanted us to test a clinically relevant dose, and they wanted us to simulate a clinical trial as good as possible. So that was very clear, that was roughly 8 years ago. And since then we have been working on the monkey model. We have been thinking about how can you apply these relatively large patches onto the monkey heart, how can you test doses which would also be of relevance for the clinic, and we are applying 4 to 20 million cells per kilogram in the monkey, and we have implanted first in 14 healthy monkeys with different dosing strategies, and then implanted into monkeys with chronic heart failure. I will not go into much detail into the 14 monkeys with a healthy heart, but I will focus primarily on the heart failure model, because that is a model that was not really existing at that time, and we based this on the work of Philippe Ménacher and Chuck Murray, who introduced LAD occlusion in the monkey model, and they did this for 3 hours, and we also did it for 3 hours, but then waited for 6 months to ensure that the damage that we had inflicted would indeed lead to a chronic heart failure situation. And what you can see on the right-hand side is ejection fraction in the monkeys and the anterior wall thickening fraction measured by MRI. And you can see that both of these parameters are clearly reduced after myocardial infarction. Interestingly, they are reduced stably over time, over 6 months, because that was an open question. Would there be spontaneous recovery of this injury? And we were not so sure, as Jay just pointed out, that you will always have a scar. Yeah, but apparently, also in the monkey model, it was very clear that when doing these interventions, scar can be introduced very reliably. And after that, we randomized these animals into 4 groups. 2 control groups and 2 groups that were implanted with EHM at a mid-dose level and a high-dose level, with and without immune suppression. I'll just give you some insight into the data that we have obtained. So one of the first questions was, of course, would you be able to see these grafts after implantation? And would they indeed thicken the target heart wall? Very simple question, but important question, because only if the target heart wall is indeed thickened by an implant, you can then also go into the second question, which would be whether or not these implants are introducing any functional changes. What you see here is now a summary of the data that we have obtained after implantation of 2 EHMs stacked on top of each other, or 5, and you can see that there is a clear dose-dependent enhancement of the target heart wall when we did so, by roughly 2 to 5 millimeters, depending on the dose, 2 or 5 patches. So then the question was, of course, is there any cardiomyocytes in these patches? Because seeing a thicker heart wall doesn't mean that there are any cardiomyocytes inside. It could just simply be the tissue that is, or matrix that is basically left. And we did detailed analyses by histopathology in those hearts. This is a heart 1 year after myocardial infarction, and you can see this very large injury here. This is a heart which was implanted with an EHM, covering pretty much the full left ventricle, and you can see here the suturing sites. And on the right-hand side, you can see a Desmond stain. Brownish are the cardiomyocytes, and you can see a big damage here, and encircled, This is the implanted tissue. And the implanted tissue comprises, roughly 60% of the implant is comprised of heart muscle. This is much more in volume than what we saw at the time point of implantation. Asking, of course, we were asking why would that be, what happened? We don't really have a lot of evidence for proliferation of these implanted cells, but difficult to study, of course, in a time course in a monkey. But what we clearly see is that the cardiomyocytes after implantation undergo hypertrophy. And what you see here is a summary of data that we have obtained by measuring cardiomyocyte volume in the left ventricle and the right ventricle. You can see left ventricle cardiomyocytes are a bit bigger than the right ventricle cardiomyocytes. And you can see here different cohorts of the animals that we had studied. 1, 2 is healthy, 3 is the chronic heart failure model, and a couple of additional control groups. And the summary of the data is that right ventricular cardiomyocytes are a bit smaller, left ventricular cardiomyocytes are bigger. At the time point of implantation, the cardiomyocytes are roughly 10,000 cubic microns in volume, and 6 months after implantation, roughly 20,000. Meaning that there is clearly a growth of these cardiomyocytes after implantation, not being exactly the same as in the remote myocardium, but providing a substantial amount of cardiomyocytes and also pretty well organization of those cardiomyocytes after implantation. And would that then change function? It does in some animals. This is the summary of these 6 animals that were treated with 2x and 5x EHM versus control in black. This is the target heart wall thickening fraction in %, and you can see that there are responders, clear responders, in which the target heart wall, the thickened target heart wall, also shows an enhancement in systolic thickening again, suggesting that there is also function, that there are some transient responders. Whether this is really transient or not is a bit open, because of course there are resolution limits also in MRI, and this is more or less a binary yes and no in the lower dose group, whereas in the higher dose group you can distinguish between different levels of enhancement. And there are also non-responders. And in particularly, I would like to draw your attention to the red one. This is the high dose group, which does have cardiomyocytes, pretty similar to the others as well. But this patch was implanted very much apically versus the others, which were more on the lateral side. And why did we do that? Because we open the chest, look at the heart, and then basically implant on the scar. And scar can be a bit variable, and in this time point, the scar was very much apically, and the patch was implanted very much apically. They're difficult to analyze also by MRI. AHA segment 17 is typically not very well in plane, and difficult to analyze also contractile performance in those regions. But it is very likely that, or it's very clear actually, that in this animal with the implant sitting here, that there was no enhancement of global heart function, whereas in the others, the large dose group and also in the smaller dose group, there was enhancement of contractility also of the global heart. So that suggests to us that also location of the implants matters, which is also not too surprising if you think about it, how the heart is moving and pumping. So if you put something on the tip of the heart, it probably cannot really contribute much, whereas if you put it on the wall, it probably could. This is at least our interpretation of that data. So interesting data as to functional enhancement by implantation and clear retention of cardiomyocytes. Is there arrhythmias, which is a clear issue with everything you inject into the ventricle? And we had, all of our animals had Reveal Link devices implanted from before infarction until the end. So for 12 months, we basically looked into all the events, and there was zero evidence for arrhythmia after implantation of tissue patches onto the heart. Why do they survive? Important question. These are not vascularized tissues. They don't have vessels at the time point of implantation. But they are designed to be extremely hypoxia resistant and rely primarily on glucose metabolism. And we did some gadolinium MRI assessments in those monkeys, and in one case we could clearly distinguish the graft from the normal myocardium. Also here, this is a resolution challenge to be precisely into the graft and precisely in the ventricle. But what you see here clearly is that there is perfusion in red in the EHM. Already as early as 4 weeks after implantation, and this is pretty similar then after 24 weeks. And that corresponds pretty well to the capillary density we are seeing, which is roughly 1/4 of the vascular density that we see in normal myocardium. And we think that this vascularization, although lower than in the normal myocardium, is essential for the cardiomyocyte growth that we are seeing, and also for their further maturation. So in summary of the monkey data, we have clear evidence that the heart can be remuscularized by implantation of EHM. It's clear that you can augment the target heart wall, and it's also very clear that cardiomyocytes are there and that there is contractile performance of these grafts to support local and global heart function. Position seems to matter of the grafts. Vascularization occurs with time, and cardiomyocytes grow after implantation. Even after 6 months, they still are not at the same volume as the native myocardium, but they are developing in that direction, which is quite encouraging. We also, with the monkey study, tested the application, the route of administration, and we're basically using a mid-cap access route, which is pretty standard in cardiothoracic surgery, and we're implanting those tissues directly onto the beating heart by suturing them onto the heart. We tested a number of immune suppression protocols, and of course, if you can test all kinds of things, but in the end, if you want to go to the clinic, you have to test something that is also clinically applicable and approved for such a patient population. And this is why we are focusing on tacrolimus and methylprednisolone, and that worked in the monkeys pretty well at actually higher doses than what you would have to apply in a human. There was no arrhythmia, no tumor, no compromise of heart function. And that was primarily the data that then led to the preclinical data in a large animal that then led to the approval of our clinical trial, the BioVet-HF trial, which was approved on December 23rd. We are now more than 2 years into that study. There is follow-up then more than 2 years on those patients, on the first patients at least. And it's an open-label, multi-center phase 1/2 trial, which has a dose-finding arm and a proof-of-concept arm. In total, up to 53 patients. We are including patients with an ejection fraction of 35 and below. All patients are in New York Heart 3 so far, actually. And they all have to be under optimal medical therapy, including also ICD or CRTD devices. The dose finding we have completed actually after 10 patients, and based on a positive risk-benefit assessment by our regulatory authorities, we are now presently continuing that study to basically already include patients for the proof of concept phase. This is an adaptive clinical trial design which allows us to work with the data as it comes in and basically then estimate how many patients should be further included. So, and here we go up to 35 patients, actually with left ventricular or right ventricular application. That is, we are focusing on left ventricle, but we also have a right ventricular arm in that study, and we are implanting 200 to 800 EHM, 5 or 20x with, or we did implant 5 to 20x EHM constructed from 200 to 800 million iPS-derived cardiomyocytes and stroma cells. Have implanted so far 150 patches, 6 billion iPS-derived cells in patients, and there is no adverse events, serious adverse events associated with these implants. It's a surgical procedure, a standalone procedure. Patients do not get anything else but the implant onto the heart, and patients are for 12 months on study, and then after that go into a registry. Which we have into a vet registry, which we started to monitor those patients until end of life. Sponsor is the University Medical Center in Göttingen. DZHK and Reparon are providing the financial resources for this, and the centers that have included patients, each of them 5, are Göttingen and Lübeck. A little bit of an overview of the dosing, how we do that. These are the patch formulations, small, mid, high dose. On the right-hand side, you can see one of those arrays of a high dose. The primary point is that these patches are covering 50 to 100 square centimeters, roughly, of the target heart wall, and they have a thickness of 2 to 4 millimeters. Again, we went through that relatively quickly and are implanting now the highest dose. This is just a little bit of an insight here on the surgical procedure. Human heart, you see one of the patches here already on the heart, and the second patch is then implanted next to the first, and the video demonstrates how this is really done. You can see that here that this is a simple surgical procedure where you basically suture then these patches directly onto the target heart wall. We have included so far, or we have treated so far, 10 patients. We have actually recruited 11, actually recruited 12 now. Next patient is implanted next week. You can see here the average of the age, 60-year-old, mostly male. We have included mostly patients with an ischemic heart disease, but also one with DCM. That was important because we are implanting only in patients in which the target heart wall is hypokinetic, and that can be, of course, in patients with an ICM disease or also with a DCM condition. A pretty compromised left ventricular ejection fraction. Some of the lowest was 10 to 14, highest is obviously 35. Patients are on pretty good therapy, as you can see here, for the proper blood pressure adjustment. Most of them have all kinds of comorbidities, as you would expect. New York Heart Association I mentioned already, and NT-proBNP relatively high. So these are advanced heart failure patients. And I'll give you now one slide in which, or a couple of slides actually, in which I believe at least, which is the most important data that we have obtained so far from that study. Our patients are, if they are qualifying on a heart transplant list, and they can be called from that list anytime. And that happened in patient number 3 that was implanted. 3 months after implantation, that patient was receiving a heart transplant. And that obviously gave us the chance to look into that heart. And what you see here now is an explanted heart from that particular patient. 46-year-old female, ejection fraction at inclusion to 25, listed for heart transplantation. 3 months after implantation of EHM, heart was taken out, new heart was taken in. Patient is happy with the new heart, and we are pretty happy with the old heart to see basically how these patches are retained. And not only retained, but also there is clear evidence that the cardiomyocytes are retained, very much so, as we have been seeing that in the monkey study. So it's completely out of the question, for us at least, that cardiomyocytes can be implanted and these cardiomyocytes will survive, and that the immune suppression protocol that we are using, which is very similar to what people are doing in heart transplantation, is sufficient to retain those. Question, of course, is this enough? This is a single layer, basically, of these patches. But you can see that the cells are pretty well aligned, and if you would look closer, you can see that there is nice cross striation, and so apparently also some sort of adjustment of the cells, adaptation after implantation. And that's again very similar to what we have seen in a monkey, and also what we have seen in monkey is vascularization. We see that also in patients. So this is at least to us very encouraging that the data can be translated from animal studies into human. What we have also gathered from that study is, of course, that the implant itself, and you can see that here, is still too thin at the lowest dose levels, and that allowed us to go very quickly to the highest dose level. And you can see the thickness of the patches here on the right-hand side. This is again in scale. So we are implanting now these patches onto the heart. And again, the question is, are they still there? And are they doing anything with the heart? Pretty fresh data from a patient that is 3 months after implantation. This is actually the DCM patient. You can see heart before implantation. You can see 3 months later the cardiac performance. And most importantly, if you look into the hearts here in this axis and in the short axis, you look at the target heart wall and look at the target heart wall down here. So you can clearly see that the target heart wall is enhanced by actually 4 millimeters after implantation of those tissue patches. So it's clear that you can add muscle to the heart, and it's also clear that this is quite nicely supporting heart function. So collectively, we have now went through animals and also now through a number of humans, tested the strategy. We know that we can put muscle to the failing heart, or even patients with advanced heart failure, even into patients which have a lot of scar in the ventricle. So it's not a problem to put muscle onto that scar. We know that these patches stay. And we don't see any dose-limiting toxicity. We are presently applying roughly 20 gram of patch constructed from 800 million iPS-derived cardiomyocytes and stromal cells. There are no EHM-related SAEs. Of course, patient selection has to be careful. These patients are on immune suppression. As you all know, patients have typically kidney disease. That is one of the key points that we have to look at, that we are monitoring kidney function properly. And the data is presently being analyzed in much detail and will be presented in the second half of this year from the dose-finding cohort. And while that is ongoing, we are recruiting additional patients to go to our interim phase at the highest dose level. These are 15 patients. We anticipate that this will be done in 2024, and the trial overall will be completed in 2025. And of course, hypoimmune patches are already late preclinical development. That is interesting, of course. It has a lot of danger itself, so one has to think about it. Probably not possible to do it without immune suppression, but that would be the next generation of implants, which do require quite a bit of additional investigations to not put the patient at risk with a hypoimmune implant. So that's our story until today. The story is evolving, of course, daily, and a couple of months later, I can probably give you some more information of additional patients. This is the group that's doing that in Göttingen. Many excellent colleagues. Malte is a key investigator in that study. And of course, we are embedded in a team of colleagues in Göttingen and outside Göttingen, which support us in our studies. Thank you very much for your attention.
Thank you. Okay, this very interesting paper is open for discussion. Yes, Josh.
Congratulations on a tour de force and in getting into the clinic. That's really impressive. Could you clarify what the primary endpoint is of the phase 2 study, and then also how important do you think it is for there to be conductivity between the host myocardium and the patch, and is there any data to that effect?
Yeah. So dose finding, of course, this is identification of the safe maximal dose according to our dosing scheme that we had suggested. Efficacy endpoints are enhancement of target heart wall thickness and thickening fraction as an endpoint that is directly related to the mode of action that we are proposing. So that's a primary endpoint, of course, and secondary endpoints like hospitalization, ejection fraction, patient-reported outcome, spiroergometry, 6-minute walk test, hand grip strength, whatever is available. So we're looking into all of these parameters. Connection between the patch and the normal myocardium, a pretty open question, I would say. Nothing can, be it cell or tissue patch, it's impossible to have the same level of connection as you would have it in a healthy myocardium. So that, I think, has to be clear. And it's, if you put a patch on a scar or if you put cells into a scar, there will always be isolating scar around. The reason why we do not see arrhythmias is probably because there is no immediate connection by chance of cells. But we do see synchronization of patch activity, and that, we believe, is by mechanoelectrical entrainment of the patches, which then synchronizes basically the contractile activity of the patches. Requires additional investigation to really clarify that.
Thanks.
You just answered my question just now. So, Dr. Fukuda.
Yeah. Congratulations on the beautiful data and the clinical trial. My question is, probably 800 million of cardiomyocytes might be sufficient if they are all alive. And my question is, how many % of the transplanted cell can survive after transplantation?
Well, we have always observed that in a tissue engineering formulation, that we can retain many more cells by a direct injection into the ventricle. And that may be because the cells are not being washed out. They are positioned on the heart in a syncytium, if you want. And I guess your question was aiming at why 800 million or so?
Yeah, you showed that the
because I
800
mean,
million.
this is what we think, or what has been reported as the cell amount that's being lost in patients with severe heart failure. Since we don't see massive proliferation of implanted cells. We believe that the cells are basically seeding, surviving, and hypertrophying after implantation, and thereby then supporting contractile performance of the heart.
Thank you.
Thank you. Next question.
Yeah, great talk, Wolfram. You answered my question about arrhythmia when you responded to Josh, but I'm still surprised there are no arrhythmias in patients with dilated cardiomyopathy because they don't have a scar. And the other question I wanted to ask is that you showed MRI of these patients, so I'm assuming, and I didn't see a lead in their heart, so how many of these patients have CRT already? Because if they have low ejection fraction, they probably have CRT, right?
They have either an ICD or a CRT-D device implanted. I cannot tell you exactly how many from one or the other, but DCM patient I believe had a CRT-D.
I mean, they have to.
And you're right.
Class 1 indication. I mean, there is a class 1 indication for these patients to
of
get
course.
CRT.
This is why we chose that. You know, we chose patients with an ejection fraction of 35 and below, because this is a clear guideline recommendation for implantation of an ICD or CRT-D in those patients. That was a conscious choice because we did not have to put pacers in because they were already in based on the primary disease and based on the guidelines. You're right as to arrhythmia introduction. I mean, in a DCM patient with clearly less scar or no obvious large scar, the risk for arrhythmia should be higher, but we didn't see that.
Very interesting.
This patient is on amiodarone, of course. Yeah.
Question on the left.
Because he had a history of VT.
Thanks, Wolfram. Very exciting.
Again, shorter answers.
Yeah. Sorry.
Okay.
Very exciting data. Thank you, Wolfram. The primary endpoint that you show, the wall thickening, is that based on strain on MRI?
It is based on the MRI is the MRI, CT, and echo. But you know, MRI primarily was our key endpoint. But we have learned now that you can forget about MRI in those patients with all these instruments. You know, if they have an ICD, CRT-D, MitraClip, and whatever, you have so many artifacts that it is impossible. You can do ejection fraction, but looking really precisely at the target heart wall is super complicated. And this is why we now shifted to CT. Not as densely done as an MRI, but CT is probably the better endpoint here, or the better measure.
And my second question, if I may, is about these arrhythmias, which is so important. So what I understand is that they are not synchronized with the with the host initially. How if they're not coupled?
Well, this is kind of what the precise mechanism of how that works is unclear. Yeah. But if you look into the functional data, and we had done strain assessments earlier in rats, but you see that the contractility is synchronized, that you can see an enhancement of contraction in systole, and you don't see a beating activity in diastole of these grafts.
Could it be mechanical, some fibrous?
We think it's a mechano-electrical coupling which is occurring.
But it's not electrical because there's clearly no,
mechanical triggers, mechanical impulse triggers electrical activity of the graft.
Okay, last question.
Okay, thank you.
Rod.
But again, important to further
Short
clarify.
answer.
Okay, so my question is sort of related to this last one. First of all, a very heroic study, and inspiring to see this done. But I could see that improvement could happen as a consequence of basically two broad areas of impact. One is passive and one is active. So the passive could be from inhibition of remodeling and lost energy into a previously dead zone. The active one is the one that you've just been talking about that's harder to assess. So my question is sort of related to this, is to what extent are you sure that there's truly active function of the patch tissue itself?
So you're absolutely right. There are more than one modes of action which are active here. One is, of course, thickening of the target heart wall, reducing wall stress, improving energetics after implantation after having a thicker target heart wall. What we see as to what the evidence as to contractile enhancement that we see is that this is not happening instantaneously. That takes time. It is typically we see that there is an enhancement of target heart wall contractility in the human after roughly 3 months. And this is dose dependent also. And it's of course limited data now. But what we believe is that the data is supporting, on the one hand, a mechanical support, passive, and on the other hand also active support, kicking in after the cardiomyocytes adapted, grew in size, are vascularized, and so on. And then we see that there is from 3 to 12 months a quite interesting impact on cardiac performance. But, needs to be clarified.
If there are no questions, thank you very much, Wolfram, for a really interesting paper. Thank you.
So it is great pleasure to introduce next speaker, Daniel Galli from University of Minnesota. So talk topic is ETV2 is a pioneer factor which reprograms fibroblast to the endothelial lineage.
Well, let me begin by thanking Kiichi and Jay for the invitation, Yuji and Victor. It's a pleasure to be here today, and I'll just highlight my disclosures. The focus of our lab has been directed towards an enhanced understanding of master regulators in mesodermal derivatives. And today, as the title suggests, I'm going to just update you about our studies focused on ETV2. Now, we co-discovered ETV2 with Casey, independent of Casey Choi's laboratory, and we were looking for NKX 2.5 downstream targets. And in a screen, we pulled out ETV2, and subsequently, we've highlighted a number of upstream regulators for ETV2. We've also undertaken yeast-2 hybrid assays to look for interacting factors. And in studies focused on attempting to understand the mechanisms by which ETV2 is expressed in a very narrow window, we identified FLT1 using a conditional knockout approach, demonstrating that FLT1, in a feedback mechanism, turned off FLT1 and thereby limited ETV2 expression. Now, in a number of studies that we undertook, shown here is just one of those where we undertook a global deletion approach compared to the wild-type mouse embryo. The ETV2 null embryo is non-viable by E8.5 to E9. And when staining sections of wild-type embryos with alpha-endomucin, you can see at low magnification a robust signal in the endocardium and vasculature present at high magnification. These lineages are completely absent, along with the blood, and thereby contributes to the lethality of the ETV2 null embryos. Now, we undertook a number of studies verifying that ETV2 was both necessary and sufficient for endothelial lineage development. And in this schematic, well known to all of you, this Waddington's landscape, we tested the hypothesis whether ETV2 could directly reprogram fibroblasts to the endothelial cell lineage. So ETV2 was not only a master regulator, but also we undertook a series of studies to define that ETV2 was a pioneer factor. And pioneer factors need to fulfill 3 criteria. One, they scan the genome and they identify their motif associated with nucleosomal DNA. They bind, they recruit other cofactors, including chromatin modifying enzymes that relax that condensed chromatin, thereby opening up and making available motifs for other upstream regulators, those that are specifying agents to promote lineage-specific gene expression. So we engineered a mouse that inducibly overexpressed ETV2. We isolated the fibroblasts. We purified them by flow cytometry, so they were absent of any hematopoietic or endothelial marker genes. And then we exposed them to doxycycline, and you can see by Western blot analysis that ETV2 is abundantly expressed in response to doxycycline. And when we use flow cytometry, these cells that are overexpressing ETV2 compared to the control, which largely has no endothelial cells, there's a robust induction of the endothelial program. And these cells avidly take up acetylated LDL, form tube assays, and express the endothelial molecular program. So we performed single-cell RNA-seq, and over time, as shown here in these UMAP panels, you can see that the endothelial cells robustly upregulate the endothelial molecular program and downregulate the fibroblast transcripts. We then went on and undertook ETV2 ChIP-seq in these MEFs that were overexpressing ETV2, shown here, and we could see that ETV2 was bound to the nucleosome as evidenced by MNA-seq. And as shown by other studies focused on pioneer factors like OSK, OCT4, SOX2, and KLF4, the nucleosomal binding of these pioneer factors, they bind to a degenerate motif. We verified that ETV2 could bind to the nucleosomal DNA. We undertook ChIP-seq and ATAC-seq studies to identify LMO2 as a downstream target of ETV2. And then in collaboration with Ken Zaret's lab, we undertook these nucleosomal binding assays. Shown here, you can see that we've increased LMO2 expression as well as ETV2, and you can see a robust binding to nucleosomal DNA of the ETV2 at low concentrations, thus again supporting that ETV2 is binding to nucleosomal DNA. Now we undertook mass spec studies to identify interacting factors with ETV2. We identified SMARCA4, or also known as BRG1. We confirmed that ETV2 and BRG1 were part of the same complex using co-IP assays, and that they directly interacted using this GST pull-down assay. You can see where ETV2 directly interacted with BRG1. And so we then undertook studies, again, in using our inducible MEF model system, where we've overexpressed ETV2 in response to doxycycline at day 1, day 2, and day 7. These are the percentage of cells that have been reprogrammed to the endothelial lineage. When we do this and knocking down BRG1, we can see that the ability to reprogram is markedly attenuated. We then undertook these ChIP-seq studies, and we identified that ETV2 was bound to the nucleosome very early at day 1, also had binding to genes at the late stage at day 7, and sustained from day 1 to day 7. And these studies just verified that ETV2 was bound initially, and then supported the notion that it recruits BRG1 to that site. Now we verified that using re-ChIP assays. Shown here, we had to prove that both ETV2 and BRG1 were associated with FLT1, LMO2, and TCF12. Again, validating that they were part of the same complex and they were recruited to that nucleosomal DNA. We went on and undertook ETV2 ChIP-seq, again with overexpression of doxycycline, day 1 to day 7, and undertook ATAC-seq, and as shown here, with this ATAC-seq, the chromatin was markedly relaxed, associated with the FLIC1 gene, but when we knock down BRG1, it remains condensed. Again, supporting the notion that the ability of ETV2 to function as a pioneer factor requires BRG1. And so what I've shown you is schematized in the following slide, where ETV2 scans the genome. It binds to nucleosomal DNA. It then recruits BRG1. And in our paper, we showed that it recruited other upstream specifying agents. And so these are studies that we've pursued. And I'm just going to finish with studies that we've focused on using this information, that is, master regulators, in an attempt to engineer pigs with humanized organs. So we focused on the vasculature, and that's what prompted our studies of ETV2. And so our approach is summarized here, where the goal is to delete the pig embryo of an entire lineage. In this case, deleting this pig embryo of its vasculature, and then complementing that embryo with either wild-type GFP-labeled porcine stem cells or human iPS cells. And so our strategy is outlined here, where we've taken porcine embryonic fibroblasts, and using CRISPR, we ended up mutating the ETV2 gene. We then used these cells and somatic cell nuclear transfer technology to produce an 8-cell stage morula, and then we transferred these into a surrogate gilt. And as shown here, just like in the mouse, the pig phenocopies the mouse insofar as the wild type has clearly blood and is viable, and by the E24 somite stage, these ETV2 null embryos are non-viable, and they completely lack vasculature and blood. Histologically, this is shown here. I don't know how well it shows up, but the wild type clearly has vasculature, both in the embryo as well as a yolk sac, completely lacking in the absence of ETV2. And so our approach was, again, engineering these mutant embryos and now complementing them with a single GFP-labeled pig blastomere, and then transferring these intraspecies chimeras into a surrogate gilt. And what we observed was that the mutant embryos were completely rescued with regards to their lethality. There was blood present here. All the vasculature is decorated with GFP cells as evidence that they were descendants of that single pig stem cell. All vasculature was labeled with GFP, and all of the blood was labeled with the GFP. Thereby, these intraspecies chimeras had a normal heart, normal aorta, shown here. Histologically, the GFP-labeled stem cells gave rise to the vasculature, not the other tissue, and these pigs were completely normal and viable. So these studies provided a platform for the interspecies chimeric studies. Now, with the delivery of a single human iPS cell into these ETV2 null morulas, and then delivery of these interspecies chimeras into the pigs. And so you can see that these human iPS cells avidly proliferate. They become associated with the inner cell mass, shown here, and these are then transferred. I should just say that we've undertaken a number of single cell analyses of both pig blastocysts, pig morulae, as well as the human iPS cells, attempting to look at barriers that might promote this efficiency of chimerism. And so we've engineered some of these human iPS cell populations. Shown here are some of our studies. in which we were able to rescue the ETV2 null pig embryo, and that all of the vasculature, this is at low magnification, at high magnification, are labeled with GFP. They express human nuclear antigen as well as vascular markers. And so what I've told you today is that we believe that ETV2 is not only a master regulator, but also a pioneer factor, and that it functions mechanistically by recruiting BRG1, a chromatin modifying factor. We think that there's other factors that are also recruited by ETV2, and we're interested in those studies, and utilizing somatic cell nuclear transfer technology and blastocyst complementation, we were able to demonstrate that intraspecies chimeras produce completely viable and healthy offspring. And our early stage studies using human porcine chimeric embryos show that they can rescue the ETV2 null porcine null embryo. So this is our group. We collaborate extensively with Mary's laboratory. The studies were undertaken largely by Wuming Gong, Javier Sierra Pagan, Satya Das, and Gunho Meng. And this just lists all of our members in our laboratory. Our collaborators, Jay Zhang, Ken Zaret, Mary, David Sachs, Randy Prather. So with that, I'll stop and be happy to take any questions that you might have. Thank you very much.
Now we open up to some questions.
Thomas. I can hear you.
Okay, exciting stories. So I was wondering about ETV2 as a pioneering factor. We also work on pioneer factors and see that it's usually they are usually binding quite broadly, but only elicit chromatin opening at certain sites. So I was wondering, maybe I missed that, when you intersect your chip sec data, your tech sec data, also looking at BRG1, I mean, is there, let's say, a full overlap or only a tiny fraction, which then also is followed by BRG1 recruitment, and what determines then the specificity?
Yes, I think you touch on a number of challenges and ongoing studies related to pioneer factors. We think that BRG1 is just one of the chromatin modifying factors. We're also looking at SMARCA5, and may have a very different role. And so the binding of ETV2 binds to many different sites, obviously, and it's only really a subpopulation. And so that's what's prompting us to look for other chromatin modifying enzymes as well.
And if you intersect with the TechSec data, I mean, do you see at all sites where ETV2 binds also opening, or only a subset?
Both. So there's obviously binding to nucleosomal occupied regions, the NORs, but also the nucleosomal free regions as well. And we think that it very well might be playing a very different role. We're also very interested in its role as a repressor to repress other lineages in order to direct the cells. We think that it represses cardiomyocyte specification, for example. Yeah, thank you. John.
Yeah, that was such a beautiful talk that I hesitate to offer criticism.
Oh, please do.
I just wish we could dispense with this term, pioneering factor, because it puts us in a conceptual framework that is misleading.
Thank you. So anyway, I was just saying the pioneer factor is a misleading term. I wish we could dispense with it, because any time you use a pioneer factor, such as OSKM, those you called those pioneering factors, they cannot act without the inflammatory signaling that's induced by the very manipulation that you're making. We showed that the retroviral vector, Yamanaka, is critical for reprogramming with OSKM. And we've studied, for the last 10 years, we've studied those inflammatory pathways that open up the chromatin and make the chromatin accessible to so-called pioneer factors. So I think it's important that we recognize that. And as we heard earlier from Victor, recognizing that these pathways, like the RNA sensing pathways, are involved in reprogramming, allows you to manipulate your therapeutic, right? You modified your microRNA so that it selectively manipulated these pattern recognition receptors. So I think it's a bad term.
Well, I'm not so sure it's a bad term, but I think you raise a number of important issues. And as part of full disclosure, John was one of the reviewers of our paper, and I will say many of your comments helped the paper to become a better paper. So I want to thank you for that. I think the point that you're making, and I completely agree with you, is that you've made, and I don't mean to say that it functions independent of other factors. As a matter of fact, it recruits a number of factors, including the inflammatory system. And we're very interested in that because we think that ETV2 directly regulates a number of inflammatory related or RNA sensing proteins independently. So I think that that's an important part of reprogramming, but there's also other factors too. And I don't want to just leave you with the inflammatory pathway that is partnering with these, what I'll call pioneer factors, because I think it's still important because they drive the initial binding to this nucleosomal DNA. But all these other factors also have to be present in order for them to function.
Thanks for a great talk, Dan.
Yeah. Thank you, John.
Thank you, Dan. Great talk.
Thank you.
All right, it's my pleasure to introduce Patricia Kim from Stanford, and she's going to talk about T-cell cross-reactivity and its role in cardiovascular disease.
Good morning, everybody. I'm excited to be here in beautiful Kyoto. I'd like to thank the organizers, Dr. Fukuda and Dr. Zhang, for inviting me to this talk. My name is Patricia Kim Nguyen. I'm an associate professor at Stanford University, and today I will talk about T-cell cross-reactivity and its role in cardiovascular disease. This is a little bit of a shift from the previous presentations, but as we know, inflammation and the immune reaction plays a role in enduring heart muscle as well as transplantation of cells into the heart muscle for therapy for heart failure. I have no disclosures. So I will start with an introduction on some of the facts about T cells, which you may already know, which is how do T cells recognize foreign invaders like viruses and tumors. So basically, there's antigen-presenting cells in our body, macrophages and dendritic cells, and they see these foreign invaders, tumors and viruses, and they chomp them up and create very small pieces that then they present on their MHC to the T cell receptor on the T cell. And this creates a priming of the naive T cell so that they then expand and become effector T cells that get rid of the antigen epitope and the antigens that are foreign invaders. So what is T-cell cross-reactivity? So T-cell cross-reactivity is basically when the peptide is shared by multiple different antigens and the T-cells react to them. So this could be good because we have a limited number of T cells in our body. This could be bad when the peptide that is foreign looks like a self-peptide. So then that causes a T cell to attack our own tissues. So there have been descriptions of diseases, most recently in Science by Gil Cruz, showing that the T cell cross-reactivity can mediate disease. In his study, he showed that peptides of commensal gut organism Bacteroides resembles alpha myosin heavy chains and activates Th17 cells to kill myocytes, basically, and causes lethal cardiomyopathy. He also demonstrated this in a mouse model and showed that antibiotics getting rid of this bacteria prevented death in the mice. So there have been other stories, including in rheumatic heart disease, myocarditis, and atrial fibrillation, but those are premature right now and ongoing. So here I want to share with you, actually one more thing I want to share is that It's also important to recognize that T-cell cross-reactivity is almost inevitable, and that's because the contact points between the TCR and the peptide MHC complex is composed mainly of 4 amino acids on the mainly on the T-cell receptor beta chain. And this is work pioneered by my mentor, Dr. Mark Davis, where he noted that the motifs that are conserved among the TCRs are usually composed of 4 amino acids, and they bind to the peptide MHC complex. So I'm going to switch gears to a story about T-cell cross-reactivity mediating viral-associated CVD. So this is something we published in Circulation in 2022. A lot of the heavy lifting was done by the individuals on the right, Dr. Roy Chowdhury, who's now at the University of Chicago, assistant professor, Jessica Diabo, who's a medical student at the Washington University St. Louis, and Dr. Huang, who is also an assistant professor in the Shantou University. So this story starts with the collection of human coronary artery plaque. We collected plaque from patients undergoing heart transplant. We FACS sorted them into 96 well plates, and then we performed a map of the TCR repertoire using single-cell nested PCR. So we're the first group to do this in the human coronary plaque. So what we found was that there was a clonal expansion of alpha-beta T cells, as shown in B, and these are pie charts which show on the right is CD4 alpha-beta T cell clonality, on the left is CD8, actually left is, I can't tell my left and right. The left is CD4 and the right is CD8. So horizontally, you see the locations of the different arteries that were collected, and vertically is the patients. And these are just 4 representative pie charts of 19 donors. Each color represents shared clones across the distributions, and they're shared at least 3 across at least 3 locations. The black is only 1 location, and white is a unique TCR. So from just the colors, you can see that they are clones shared across the 4 locations, and there's mainly CD8 alpha-beta T cell clonality, but there's also some CD4. And in C, we see that we're mapping the clonality by graphs, and we see there's no difference in the location of the arteries, the clones in the location based on location of the arteries. And in D, you see that CD8, but it's not CD4, seems to track with disease progression. So we wanted to understand what antigen epitopes activate the plaque T cells. And how we did this was we sequenced the TCR alpha and beta, and we matched them across databases of known T cell specificities. So to our surprise, they matched mainly viruses, and maybe because the databases are full of viruses, or viral epitopes. But we did see that there's about less than 1.5% per virus, flu, CMV, and EBV. Other is non-viral, that matched exactly. So we also see on the graph C that these viral TCRs were across different phenotypes, mainly in the lipid and fibroatheroma stages. So less than 1.5% doesn't seem that high, but if you look at a paper by the Lay group in San Diego, published in Circulation 2020, he looked at T cells specific to ApoB as an autoimmune mediator of atherosclerosis, and he found about 1.7%. So it's in line with that. In addition, we know that atherosclerosis is not mainly a autoimmune disease. And finally, in D, we do show that these viral specific T cells are present in all our donors. And finally, E shows that even though 1.7% seems small, when we look at the motifs, the viral motifs, as I explained earlier, it's about 30%, so that's actually quite high. So we weren't looking for viral specific T cells in the plaque, but we found them, and it does is interesting to note that we know that myocardial infarction the risk of myocardial infarction is high after having a flu infection, and there are many epidemiological studies demonstrating this, but perhaps the most robust is the one from Kwong in the New England Journal of Medicine, where he compared the rate of myocardial infarction 7 days after having a documented flu infection with the control period, which is 52 weeks before and after the influenza detection date, and he found a 6-fold increase in the rate of cardiovascular events. And this rate is higher in older people and in patients infected with influenza B. It's not as different in males and females, or based on vaccination status, or if you had an MI in the previous period. So back to our story, our patients aren't infected at all. They are patients receiving heart transplants, so they should not be having any flu infection or any other infection for that matter. So we wondered why we found these this virus-specific plaque T cells in our patients. And we looked for some cross-reactivity between the viral epitopes and self-epitopes. And how we did this is we used a computational algorithm to find nucleotide and proteomic sequences that are shared among viral epitopes and self-proteins. And what we found is shown in B and C, where we compared some proteins in cardiomyocytes, endothelial cells, smooth muscle cells, and we found a series of proteins that had similar homologies between the viral epitopes and the self-peptides. So that was a computational analysis, and we wanted to prove that in vitro, so we performed a Jurkat stimulation assay to confirm that there was T-cell cross-reactivity between the viral and self-antigens. So Jurkat cells are a cancer line, T-cell cancer line that does not express TCR. So you can put your chosen TCR on that cancer line and then expose it to T2 cells carrying your cognate peptide. So in this case, we chose a flu-specific TCR. We put it on our Jurkat cell, and we exposed it to a HLA2 T2 cell that was presenting an M1 peptide. In addition to our self-peptides, T-span 17 and ZIP9. T-span 17 is a transmembrane protein that regulates leukocyte transmigration. ZIP9 is a membrane androgen receptor that is a zinc transport protein. So how you read the activation of the T cell is by CD69 expression on flow cytometry, and on B, you can see the dot plots showing that the TCR was activated by the M1 flu peptide at the highest level, followed by ZIP9 and T-span 17. So it's expected that they would not activate the self-peptides would not activate the TCR as much as the M1 peptide. But it does show there is cross-reactivity. So what about coronavirus? So we did look at this, and we did find that there were viral epitopes specific for coronavirus in the plaque T cells. However, this is not HLA restricted. And this is interesting because similarly, coronavirus COVID infection has been associated with acute complications, acute cardiovascular complications, thrombotic complications. In addition, there's this recent paper that these complications are long-term. This is a paper by my VA colleagues that used ICD-9 data, administrative data, and they found that the burden of cardiovascular burden, the risk persists up to 1 year. The major adverse cardiac events are about 25 per 1,000 persons, and any cardiovascular outcome almost 50 per 1,000 persons. And they showed that this was present, the higher risk was present, the highest was ICU patients, then hospitalized, but even non-hospitalized patients had increased cardiovascular risk. Whether the T-cell cross-reactivity explains the long-term complications of COVID remains unclear, but is worth studying. So how about T cell cross-reactivity due to the mRNA vaccines? So this is a very rare complication, 12.6 million vaccines, but only like vaccines given, but only like one case, and mainly in young males. And although it's rare, it's something that dissuades people from getting vaccines, so I think it's an important thing to consider that this may be happening. So just switching gears a bit, I want to tell you another story about T-cell cross-reactivity meeting ICI myocarditis. So we talked about viruses, and now we're going to talk about tumor. So ICI myocarditis is basically immune checkpoint inhibitor myocarditis, and it is basically caused as a result of immune checkpoint inhibitor medication that releases the brakes on T cells to treat cancer. So basically, there's a monoclonal antibody that blocks these checkpoints that prevent the T cell from activating and doing its business, basically. So of course, there could be complications when the T cell starts acting against your own tissues, causing inflammation and reaction. So myocarditis is the most deadly, potentially deadly complication. It's very rare, but very deadly. And in here, on the right, you show, in the cartoon, you show why this can happen. And the right shows the T cell infiltrates that occur in myocarditis. So this is the work by a mentee of mine and Sean Wu's, Dr. Han Zhu, who's now assistant professor at Stanford University. And she basically looked at a mouse model and patients with ICI myocarditis. In the mouse model, in the mutant mouse model, she compared the blood sample and heart sample for mice with and without myocarditis. These mice developed sudden, spontaneous myocarditis. She looked at the immune signatures using a single-cell RNA-seq. So in B, you see all the subsets of CD45 cells found in blood and plaque. In C, you see that the mutant mice have higher levels of T cells and monocytes and macrophages in the heart, not so much in the blood. And then D shows that the population of CD8 specific cells, and E shows that the expansion is mainly in the effector memory cells. This is in mouse. And expansion is mainly in the heart. So how about patients? So we also looked at patients, and group A is patients who are on ICI but had no complications. Group B were on ICI but had complications not heart-related. C is patients who were on ICI and had ICI myocarditis. So A shows you the single-cell RNA-seq data for the patients, and also the clonal expansion, which shows that most of the clonal expansion is in group C. As a reminder, this is blood. This is not heart muscle data. This is blood data. So B also demonstrates a high number of CD3 cells in the group C patients who had myocarditis. And C shows that the clonal expansion is in a special subset of CD8 cells that are called TEMRA. They have re-expression of CD45RA. Their function is unknown, but they have specific profile. And D just shows the clusters of CD8 cells, mainly highlighting the TEMRA cells are the ones that are significantly expanded. And E shows their profile, and they seem to have more activation and cytotoxicity and a higher level of chemokine expression and homing genes. All the clusters have some level of exhaustion. So interestingly, there was one patient where we had multiple time points, and this patient, there was an early blood draw at day 0 where the patient had active myocarditis. Day 65 was when he did not have active myocarditis, and as you can see from the troponin levels in A. B shows you his cardiac MRI. The first image is a delayed enhancement, which shows there's a little bit of scar there. He does have some also myocardial thinning. The next panel shows T2 mapping, which basically shows evidence of myocardial edema, which is characteristic of acute myocarditis. Late at day 65, he still has evidence of the gadolinium uptake, which shows scarring, but he does not have the edema that was noted early. But when we look at his blood, he does have, in early stages, a high level of clonal expansion. Late, the clonal expansion persists, and although it's a little lower than the early stage, and the area that is clonally expanded is the Temra CD8 population, as you can see in D. So it's interesting to consider if this T cell cross-reactivity issue is a mediator of ICI myocarditis as well. And across the bay, another group, actually a colleague of ours, Dr. Mosley at UCSF, was looking at the antigen epitopes that might be activating T cells. And he found in a mouse model that alpha myosin was actually the potential epitope activating CD8 T cells. And then he looked at the blood of patients. He collected multiple samples, the muscle, the gut, as well as the blood and the heart. And he found clonal expansion mostly in the heart of patients with ICI myocarditis. And then what he did, which was, I thought, interesting, is he took the PBMCs from the patients, expanded them, but he exposed them to viral epitopes, EBV, and influenza, expanded them, and found that there were a higher level of TCRs reactive to alpha myosin in healthy controls as well as the patients. So the question is, I mean, he had to use epitopes viral epitopes to expand these cells. So it's a question whether there is a cross-reactivity that exists. That wasn't mentioned in the paper, but something to think about. So future directions for my lab, in collaboration with Mark Davis, is developing or applying what he developed, a spheromer, in contrast to a tetramer. A spheromer allows you to have 12 MHC peptides attached to a base and expose them to the blood. So it has higher sensitivity, as shown here in A. It can detect lower binding capabilities of the peptide MHC to the TCR. So the tetramer only allows 4, the spheromer allows 12. And then we could potentially attach our peptides that we think are cross-reactive to this spheromer and expose it to the patient's blood that had some complications and determine whether those are the peptides that are activating a cardiovascular complication. So the spheromer also has higher specificity, as shown in these flow diagrams, where there's better segregation of the population that is positive. In addition, there's a potential for CAR T cell therapy in these patients. We could potentially create a CAR T cell that basically kills the cross-reactive T cell. Alternatively, we could create a CAR T cell that modulates immune interaction by binding to the APC that presents the cross-reactive peptide. So the take-home messages are that epitopes from foreign antigens can mimic self-peptides and activate T cells to cause acute or chronic inflammation. T cells found in atherosclerotic plaque and in blood of patients with ICI myocarditis are clonally expanded and track disease progression. Some T cells found in coronary plaque cross-react with viral peptides and self-peptides, suggesting a potential mechanism for viral-associated CVD. Further work is needed to validate these observations and to develop tests and therapies for those at risk. So I thank you for your attention.
Patricia, a very nice paper. It seems to me that your observation is very provocative, and I think the big issue is where do we take it next? How do you actually demonstrate causal relationship and develop therapies for it?
Well, the one thing in the last slide, or the second to last slide, so patients have known complications of flu infection, cardiovascular complications of flu infections and coronavirus. We could take those people's blood and screen them with the spheromore and attach the specific peptides to that and see if they have activation of their T cells. We can then we can also do adaptive transfer models to see if those, in mice, to see if those reactions cause disease. So that's how I'd pursue that.
So if you find those people at risk based on spheromoles, what kind of actions or management you would undertake?
So if I find the people at risk, certainly we can develop the blocking agents for those activities, or immune tolerant T cells, like Treg cells that modulate the risk and bind to those epitopes. So we can modulate the immune reaction, basically, using the Tregs.
Any other questions? Well, thank you very much for a provocative paper. So the last one is going to be given by my co-chair, Yuji Nakada, who's from University of Birmingham, Alabama, Birmingham. And he's going to talk about pig double injury heart model extends cardiomyocyte regenerative capacity through redox regulation.
Thank you very much for introduction. This is a great opportunity to involve me to such one of a part of like organizer, and also thank you very much for like a supporting team to make this meeting great. So today I'm going to talk about something about the pig double injury model and also related redox signaling. So cardiac regeneration. So cardiac regeneration is very promising, like the study recently, like the rapidly advancing like a field of like medical research, and so focusing on like damaged damaged cardiac muscle, recovering like a damaged cardiac muscle, and also the recovering like a cardiac structure and function. So, and especially originally in 1971, the newt is originally known. Actually, the newt is highly known to regenerative animal, including like a tail and the limb. And also no wonder the scientists study about the cardiac tissue also. And after that, zebrafish is 2002 the year, and known to regenerate the cardiac muscle. And long time, scientists has not known about how it's mammalian, because probably most of the scientists believe that the mammalian cardiomyocyte never regenerated. And 2011, the breakthrough study was found by Hesham Sadek group, and the neonatal mouse also can do cardiac regeneration. And so they showed apical resection and also myocardial infarction, and they recover after the 3 weeks later. The cardiac muscle is totally recovered and accompanied with cardiomyocyte proliferation. And so after this, and however, this regeneration is limited. I think, as IJ said, the 7 days after past this time point, so they're never going to regenerate it, and the cardiac muscle. And the long time, also not known about the large animal, and the J is 2018. So as he also presented it, and also Singapore group, and simultaneously published, the large animal also can do cardiac regeneration. And however, this case also similar to the mouse, only like 2 days, I think, limit to the cardiac regeneration. So accompanied with proliferation of cardiomyocyte. So we wondered, we tried to think about how to elongate this like cardiomyocyte, the extension, the window, to furthermore like later neonatal and also like adulthood area. So we found that we call the double injury model. So first, the apical resection was performed. This one is a pig model, and the P1 neonatal pig apically amputated the apex. And following the 4 weeks later, we performed the myocardial infarction and the secondary injury. And further 4 weeks later, we harvested the heart to see how its function and the structure was recovered. So interestingly, so this figure showed, this is control myocardial infarction only, no apical resection. And this one is double injury model, apical resection, and also followed by myocardial infarction. So completely regenerated cardiomyocyte, and the echocardiac function also back to the no difference with the control mouse. And this also confirmed that cardiomyocyte proliferation, including like PH3, Ki67, and also cytokinesis marker, or B kinase, and we show that this is completely regenerated as amazingly. So we wonder the mechanisms. So this one is we are very interested about we know this phenomenon has happened, but we don't know why, how this regeneration is occurred. So we tried to set up some like single nuclear RNA seq analysis and the various injury group and the time points. So including apical resection P1 and secondary injury, the myocardial infarction. And after we harvested several different time points, and also including myocardial infarction only, this is non-regenerative, and also control group is, and including like embryo. And we performed the cluster, actually the high quality nuclear was harvested each group, and we performed the single nuclear seq analysis. And this one, the UMAP showing, we identified quite interesting the different type of cardiac tissue, cardiac the markers, and especially like these cardiomyocyte marker we check and found 6 unique cardiomyocyte clusters. And each came from like a different lineage, different cardiomyocyte types. And so distribution analysis we perform, and each experimental group and the time point across, and we found quite interesting. For instance, P56 is almost 96% contributed to the CM2 region. And P1, neonatal, is almost, this one was 96% CM3 contributed. And embryo is, I think, 92% the CM6 region and contributed. And CM4 and CM5 is pretty much came from the double injury group, almost like 69% CM4 and 98% CM5 that contributed these genes. And CM1 is quite a heterogeneous population and came from almost of all, and this double injury group, and also some of P28 and also myocardial infarction group also. And so we check trajectory analysis because this information also important to know which cell turn to be which lineages. And so the center point is CM1 population. We see, we identified 3 proliferative lineages, and the CM2 is the P56, so non-proliferative lineages. And CM3, especially before that, we just checked the G2M score to see how is the G2M, cell cycle is activated among of these clusters. So, and the CM6 and embryo, and also like CM3 is the P1 is highly elevated, and also CM5 also almost same grade elevated, and compared to the other cardiomyocyte group. So we are And this one is, we trace the lineage to this CM1 group to CM3, P1 like the lineage tracing, like 0.83% contributed this cardiomyocyte to PE3, like P1 like phenotype. And this one suggests some like gene ontology is like G2M transition cell cycle and the androgen receptor, something try to be more mature, turn to be more mature like a step. And also another trajectory pathway, fetal, like 1.09% contributed the CM1 to CM6 pathway, and insulin like growth factor receptor, and also like notch signaling, TGF beta signaling is activated compared to like CM1 lineages. And so the left CM5 proliferated because G2M is quite activated like CM5 clusters also. And this one contributed 6.89%. And mTOR pathway also activated, and also UNT signaling is activated. So almost the total sums up CM1 and CM3, and almost 2% of the cardiomyocyte perinatal like phenotype to show more proliferative phenotype, and the CM5 is like almost 7% contributed to proliferation phenotype. We think about it, and this one is a heat map. We check, as I said, like we kind of interested in CM5 because not only the G2M score is high, but also we found that the PKM2 is high in CM5 population. So, and like Jay also mentioned about the Liu Zhangji group was published the paper, the PKM2 overexpression recover cardiac structure and function. And so we just interested, like this CM5 might be interested the population to study. And next step, we check the PKM2 expression pattern. And so this is myocardiac infarction only, and also this is a double injury model. And double injury model is quite significantly increased the PKM2 expression. And as you can see, like the yellow, like the troponin and also PKM2 expression is much too elevated compared to the myocardial infarction only. And we next check the qPCR to PKM2, and so PKM2 is interestingly significantly high in the double injury group. And also we wondered G6 6-phosphate dehydrogenase is a downstream pathway of PKM2, and this the group, this gene also elevated double injury group, and we believe that some mechanism is the PKM2 elevated is activated PPP pathway, because G6PD is the first enzyme of the PPP pathway. And also this one is glycolysis gene expression. We check among of the cardiomyocyte clusters. And the CM5 also the almost close to the neonatal and the fetal level. And so one of evidence is the glycolysis pathway is elevated like a double injury group. This might be contributed. And so since G6PD is activated PPP pathway, and the PPP pathway is also generate like not only the hexos, but also NADPH, and NADPH also working as the reactive oxygen species scavenger. And so next we check the dehydroxylrhodamine staining to detect the reactive oxygen species, and myocardial infarction only quite significantly elevated the reactive oxygen species detected, and instead double injury model is significantly low. And followed by, this is the DNA damage, the hydroxyguanosine to see the base excision of DNA damage. And the myocardial infarction only is significantly elevated. And instead, the double injury model is lower the DNA damage. Here's a brief scheme of the pathway we expected. The PKM2 elevation caused by myocardial infarction and the double injury and activated glycolysis 6-phosphate dehydrogenase and followed by PPP pathway. And so this one generates NADPH and also this suppress reactive oxygen species and suppress DNA damage. So we believe that Hesham Sadek group also published that one of the key regulation of cardiomyocyte cell cycle arrest is DNA damage. So they also show that the scavenge the DNA damage increase like proliferation of cardiomyocyte. So this is one of expected mechanism. And of course, there's more pathway is possible, but this is one of my suggestion to this study. And so lastly, last couple of figure is the proportion of cardiomyocyte expression genes for associated cell cycle phase, each individual the group and the surgical model. So compared to the myocardial infarction only, the right side, S phase is the lower and compared to double injury model. And this is native like a fetal P1, P256. And the G2M genes expression also increased the double injury model and compared to the myocardial infarction only. And so this one is the opposite of cell cycle marker. This one is cardiomyocyte mature gene and adrenergic signaling and the Z-disc and also cardiac muscle contraction genes. If compared to the myocardial infarction only, the most of the double injury model is lower expression compared to the myocardial infarction only. So here's a summary of my this study. We have successfully developed a double injury model and demonstrating for the first time the extension of the cardiomyocyte lineage window in a large animal and the transient expression of CM5 cluster induced by the apical resection appear to play a role in muscularization and functional recovery by activating glycolysis pathway and reducing DNA damage following the second myocardial infarction. And the apical resection part of the cardiomyocyte maturation, which is believed to contribute to the recovery process after the second myocardial injury. So I say thank you very much for the Jay and the very great team to help to this study and the core facility help to us to analyze the RNA-seq and also our collaborator, the Dan. We have a great thank you for the collaboration. And thank you very much for now I take some questions.
Thank you for a nice paper, yes.
Actually, we did not have like a direct evidence of like a PPP pathway as expects, like not like a HPLC tested or anything yet, but we just assume that like a PKM2 expression is increased the PPP pathway because the G6PD was elevated. So, but we don't have, right now we don't have direct evidence.
Okay, so basically what you're saying is that glycolysis is increased, pentose phosphate pathway is increased,
Yes.
both of them.
Yes.
So how could it be? Are you saying there's more glucose gets into the cell? If that's the case, you should also show that, glucose uptake is increased into this cardiomyocytes. Otherwise, you cannot support both of these pathways, right?
Yes, but the PKM2, I think PKM2 have quite like the work as like a dimer and also tetramer, and they can exchangeable. And dimer is more like a low activity, and the tetramer is more highly activated glycolysis, and also I think the like PBB pathway also. Like
Well,
both.
yeah, PKM2 would have an effect on glycolysis, whether or not it goes into the TCA cycle or if it goes into lactate. But it wouldn't have an effect on pentose phosphate pathway. So to do that, to support both of these pathways, you need to bring more glucose into the cell. So you need to increase glucose uptake and glucose phosphorylation both. So otherwise,
Yeah. I think you are you are right, but we don't have right now direct evidence to
Okay.
to,
All right, thanks.
one of
Thank
pathway
you.
or both pathway activated.
Thank you for that question. Dr. Bowley?
Congratulations, very elegant, very exciting data. So it seems like the apical resection is kind of preconditioning the heart to shift its phenotype to a pro-regenerative phenotype, so to speak. And I have two questions. One is, what is the time course of this shift? So you did your infarction 4 weeks after the apical resection. I wonder if you try to look at later time points to see how long this phenotypic shift lasts after the apical resection. And secondly, I was intrigued by your data on ROS, anti-ROS mechanisms induced by the apical resection. So I wonder if that apical resection is upregulating the antioxidant defenses such as endogenous superoxide dismutase, catalase, glutathione peroxidase, etc. Have you looked at other antioxidant gene expression in this model at 28 days after the apical resection?
Okay, maybe I can answer second question first, but we didn't not check the other like DNA mutations or so, because we right now have like evidence is DHL and the DNA damage marker. So and maybe the possible the other like a reductase is activated and including like a glutathione too, but we can maybe think about the next.
So that could be a mechanism for what you're seeing. Maybe you're just upregulating the endogenous antioxidant defenses of the heart. Right?
Yes.
And the time window, how long does
time
this
window is we did the maximum is 4 weeks after the second myocardial infarction, and also we harvested even like after 2 days, and also like 7 days, and something like time point. We see even like early time point we can see some like less scar, and so probably it's first like myocardial infarction already contributed, like as you said, like preconditioning, like that's why the one of mechanism is originally they did not develop scar a lot because already preconditioning like prevented some like making a scar.
But if you do your infarction, let's say 2 months or 3 months after the apical resection, you still see a regeneration?
We did only the 4 weeks after the second myocardial infarction, but could be possible, but we don't know how long this signal is lasting.
Thank you.
Thank you. Next question.
Thanks very much. I was wondering to which extent confounding factors could play a role. Wouldn't you expect that the initial insult, the apical resection, would lead to a different pattern of vascularization? So in other words, are you sure that the initial death after LAD ligation in this area is really the same as in a non-injured, non-AR group?
So this second injury is the same pig as like first the apically dissected the pig. So is that your question?
I mean, you talk about regeneration, but it could as well be that the cell death or the degree of injury is different in the AR group compared to the control group. Because, for example, the vascularization comes from another site. That would be a very simple explanation. So did you verify that with your LAD ligation, the same amount of initial cell death is induced?
Oh, you mean like only like a myocardial infarction only, and there's a double injury model is same amount of like a cell death?
Yes.
That's happened. Actually, we did not. That is a good question, and we did not we did not, I think, directly compare to like, but the surgical, the model is we did exactly same as like a ligated, the similar degree, and we should see, but as second ligation we did, this gonna be not happening like after we even harvested like 2 days and 5 days, it's less cardiac scar. But we did the echo cardiac function, and this one is already like significantly going down after the myocardial infarction only. But it's getting
it's
like recovered.
less.
So.
Yeah, thanks.
Thomas?
Actually, similar question as Thomas, but I also have a second one. Was wondering, did you also look for HIF-1 alpha stabilization? And DNA damage is pretty well known to induce HIF-1 alpha stabilization. You show that there's reduced DNA damage, so wonder whether there is any change in HIF-1 alpha, which could, of course, also impact.
Actually, yes, that's a good question. And this study, we did not directly check like a HIF-1 alpha, but it's also a possibility to involve like a HIF-1 alpha to like related to PKM2 like expression.
Still related, Thomas' questions. I mean, we also did similar experiments with this repetitive damage in neonatal mice. Yeah. And there, in fact, we saw dramatic, which never happens in adult mice, of course, that there's de novo formation of arteries. There's also a paper from a Chinese group a couple of years ago reporting similar things. So I think it would be really worthwhile to look whether the vascular tree after this initial damage changes or whether it stays essentially the same. And then your standard type of ligation might do something else. Yeah, I think that's really important to figure that out.
I see. Yeah, thank you very much.
Question
Yes.
over there.
So I thought quite interesting that regenerating myocardium activate like a Warburg, like cancer Warburg effect. And my question is very similar to Dr. Aldehari. And so when glycolysis is activated, many other pathways can be activated, such as serine pathways. And so do you think that among those accessory pathways, the pentose phosphate pathway is most important? Do you have evidence of that?
Actually, we don't have other pathways activated evidence, but is that possible? Because yeah, PPP pathway. Right now, we just only identify PPP pathway is very important because PKM2 was elevated, and so. But that is good suggestion. Thank you very much.
Thank you. Questions there?
I might miss this one, but the so you did the air and then did airway ligation, but where ligation occurs in terms of relationship between the regenerated cardiomyocyte in the after the apical resection, is that very close to the apical resection site or away from the apical resection?
Actually, it's not, I think, away, more like close to, I think, apical resection area. And this, we show that is a border zone area, which close to the infected, like a ligated area, so, and nearby.
Yeah, the reason why I'm asking this question is if you ligate a little bit away, then you can make a proximal site that are not regenerated cardiomyocyte, right? So you might
I think yes, yeah. The ligation site, if you do the more close to the base site, it's going to be more increased, like more severe cardiomyocyte infarction, and also I think this is our surgeon in constitutively, I mean, consistently the ligated the same portion as compared to the control, and so I think it's not really close to the base site, more like the middle or like close to the apex area, lower.
Thank you.
Thank you. Okay, Jay.
I usually do not stand up help the colleagues' questions. So there's a few questions that probably I can clarify. So first, the ligation position. It's in pig heart. You can see clearly the 3 diagonals. So the ligation is always done by post-second diagonal. So it's anatomically positioned post-second diagonal AOD ligation, which always result in an anterior apex infarction. Okay, that's first question. To Dr. Bowley's question, the time course of the gene change, we have done the explant heart 2 days, 7 days, 14 days after the second injury to look at the gene profile change. And the data, lots of data coming out. So the potential we see is when the early, 2 days after the ligation, 7 days after the ligation, which explant heart see a big piece of scar. Some genes, for example, PKM2 is highly expressed. When by 4 weeks, when the remuscularization, quote unquote, is completed, this gene is tend to decrease. So when that indicates that these genes are related with the regeneration. Likewise, we have done the first injury. So after the apex resection at 2 days, 7 days, 14 days, we want to see the profile change if that's similar to the second injury. The data have not come out yet, so it takes lots of time. But we have designed the explant heart 2 days, 7 days, 14 days after the first injury, and 2 days, 7 days, 14 days after second injury. So there's lots of data. All the data will upload to the cloud and for the public to share.
Yes,
and
Roberto.
Answer the Thomas question. So as I said earlier, I have done thousands of dogs and hundreds of pigs with AOD ligation without the apex or early neonatal injury. So it always ends up a big piece of scar. Compared to with double injury, when you have either AOD ligation or apex resection, you can only ligate AOD one time. So that's why the latest study is done apex resection. So compared to with the P1 injury, the AOD ligation result in control group regenerative, non-regenerative heart versus regenerative heart with the P1 injury is a huge difference. You can see by naked eye, basically. That's what we see.
Thomas, you want to use microphone?
You just said that the initial injury after LAD ligation is different in the AR versus the control, right?
We didn't say that. We do not know. It's just A1 or A2, P1 or P1 injury make a regenerative heart. That's the conclusion. If you the injury is happening in P3, P7, P8, it results in big piece of scar. So the P1 or P2 injury make a heart a regenerative heart. If the injury happened beyond the P3, it's result in non-regenerative heart, in large mammal. That's what we found.
No, sorry, but I think the key question for
discussion. Yes, sure.
The key question remains whether however you measure it, the size of the infarction after LAD ligation differs in the AR model after the
Absolutely, absolutely. So it doesn't matter. It doesn't matter its size. It's the matter the time of application of the injury. That's the point. Thank you for asking.
I have a feeling he's not quite convinced yet. So, yeah, I think you guys should have a little debate. Roberto.
Very quickly. So, yeah, it's a fascinating model. I'm really intrigued, and I think it's enormously important. My question was, you do your resection on the first day and do the LAD ligation 4 weeks later, right? And you see regeneration. What if you do your ligation 2 months later, 3 months later?
So we do not know. We have not examined the time course of regenerative heart. We dial down sometime. We have not studied that yet. So
Yeah,
that's
he will be
important. It's a regenerative heart. There's a time window. Here we see it's about 4 weeks. That's what we examined. Back to your question, Thomas. Again, it's not the infarct size we compare. We compare the infarct size of AOD, not the apex. AOD ligation apply the same post secondary diagonal, and they compare with and without injury. That's what we compare, but not the apex part. Okay, good, thank you.
I think all right.
I did. So the with and without a P1 injury, if you apply same AOD ligation, the scar size is a huge difference. That's what we see. Initially, yeah, we did that. Yeah. Oh, we did that. So that's a good question. Thank you for asking. But the data is in the publication. So we did it, like, say again. So 2 days after AOD ligation, explant heart, we see if there's a scar or not. It's a big scar. 7 days after the AOD ligation, double injury, big scar. By 4 weeks, the scar is gone. So both UG and me presented. So there's a double injury, then we explant heart in subgroups, P30 after the 2 days after double injury, 7 days after double injury, and then 4 weeks after double injury. We compare, we want to examine if the no scar is because the injury is different. So we explant the heart 2 days after the second injury, 7 days after the injury, there's a huge scar by that time. It's just like we see all the time. Yeah.
Okay.
Answer your question? Yeah. It's published. It's in the circulation.
Eugene,
it's published.
I hope he was helpful to you. He's the white knight to try to help you. I don't think everybody's fully convinced. All right, Roberto, last question.
Right. Not a question. So I think, Jay, you answered the questions by Tom that you do not have, you do have a severe injury even after apical resection early on with cell death, and then you have regeneration. You see a big infarct 2 days after the occlusion, which is what Tom was asking.
Right,
so
right.
The initial injury is the same in your resected heart. That's very important. I think in the future it will be fascinating to look at how long this preconditioning phenomenon persists, how long you can keep this phenotype of pro-regeneration.
Thomas, are you convinced? Are you convinced?
So the question is whether the adult heart, whether you somehow make the regeneration, what's the time window of regenerative heart?
Right.
We have not examined that yet.
I think it will be fascinating to look at.
Well, you know, it's a good thing I gave a talk that's shorter than 1 hour, so you have plenty of time to debate.
Right.
But now the time is up, and I guess what we're going to do is for a break.
Oh, Dr. Fukuda has arranged a photo session, so everyone go out to make a photo. Yes.
Okay, photo time. Thank you.